Dr. Fesi, for that, for finding some time in between your busy schedule to inaugurate our CME program. So thank you once again. So, and with that few words, we'll go back to the CME, back to Dr. Saijas.
Thank you. Thank you so much, Dr. Fesi. Thanks a lot, KM, again for giving me back this session. We are going on to the second session of the day, and which is on a very, very important topic, that is endometriosis and infertility. And to speak about that, we have a very wonderful apt person, the chairperson of the Infertility Committee of FOGSI. Now, before I move on to the speaker, I would love to introduce the chairpersons for this particular session. I'll share the slides. Hope you can see my slides.
Yes.
Yeah, thank you. As the first chairperson for session number 2 is Dr. Jyoti Chandran, Madam. Madam is the additional professor in OBG at Government Medical College located at KOZHIKODE. Madam is the president of the Calicut Obstetric and Gynecological Society, has been the vice president of Kerala Federation of Obstetrics and Gynecological Societies in 2018, the corresponding editor of Journal of Obstetrics and Gynecological Society of India between 2017 to 20, and the member of Institutional Research Committee since 2016. Her field of interest are endoscopy, high-risk obstetrics, and fetal medicine. To chair the session along with her, we have another young gun, none other than Dr. Sharath Devadas. Sharath is the consultant and reproductive medicine specialist at Fertility First, the fertility segment of HMS Hospital at Kottakkal in Malappuram. So it's a privilege to introduce the two chairpersons. I will welcome both the chairpersons and humbly request Jyoti Madam to introduce the next speaker, none other than Dr. KUNDAN, who would be speaking on the topic of endometriosis and fertility. Jyoti Madam.
Thank you, Dr. Saijas, for that introduction. And we are happy that you have taken, the KFOG Reproductive Medicine Committee has taken up this topic, which is of such a grave importance. And to introduce the speaker, Dr. KUNDAN INGALE, Chairperson Infertility Committee FOGSI 2020-2022. He had award for Best Research Paper in ISAR in 2019 and second Best Research in 2018. Third Best Research in 2019. Is the director, Nirmiti Clinic Center for Assisted Reproduction Endoscopy, Pune, General Secretary, FOGS, founder, treasurer, Maharashtra Chapter of ISAR, founder member, Pune Association of Gynec Endoscopic Surgeons, presented research papers at various fora, and he is director, Moses Basket Art Bank, Pune, presented first time research at KOZHIKODE World at Vietnam, and on use of GCSF subcutaneously for thin endometrium. On to you, Dr. KUNDAN.
Good evening, ladies and gentlemen. Thank you, Dr. Jyoti, for those kind words of introduction. Thank you, Kunji Mohiddin, a very good friend, dear friend, for inviting me for this KFOG Reproductive Medicine Committee workshop, CME. Today, let me share my presentation first. Just give me a few seconds. Yeah, today I'm going to speak on endometriosis and infertility, or ART. That is my topic, because I think we have already discussed in our first session about medical management of endometriosis. And I think wonderfully we have understood the scope of medical management, indications and various drugs and where to use which drugs. So I think very interesting talk. The second one is, as we know, endometriosis, the most commonly one of the presentation we come across in these patients is infertility or subfertility. So very important topic to be discussed, and I'm going to get you some evidence about different management according to the stages. So friends, we know endometriosis was invented by Karl Rokitansky, and presence of endometrial-like tissue outside the uterus, which induces a chronic inflammatory reaction. And I think the most important, I always insist when I talk about endometriosis, is these three words. Those are chronic inflammatory reaction, because the reaction which is producing some abnormal inflammatory cytokines, and all that leads to a interference into the fertility. And as it is a chronic problem, it happens, keep on happening repeatedly. So there is obviously going to be a recurrent chances are very, very high. As I understood, as I discussed, infertility population almost 50% patient, though they may not present to you with dysmenorrhea, but with infertility, and we find endometriosis in them. If you look at the group who presents to you with a chronic pelvic pain, almost 71 to 87%, pretty high percentage, the diagnosis is endometriosis. Now, for all practical purposes, we follow this revised American Society of Reproductive Medicine classification. And this classification was designed because it will help us to stage the disease. Now, why do we stage this disease? Because we want to draw the management strategies according to the stages. And also it will help us as a clinician to tell our patient about the prognosis of the disease, how it's going to kind of impact on the fertility, or how it's going to evaluate or affect the future recurrence. So it is basically based on a lot of different lesions what we see on the peritoneal surface or ovarian implants, whether how much is the ovaries involved, whether it is single ovary or both side ovary, what type of lesions are there, and how many how much extent of adhesions in POD as well as in adnexa. So all these points keeping in mind, each point has got a score, and when you collectively score it after laparoscopy, we have stage 1 to 1-4. I need not go into detail, everybody knows about this, but quickly we'll brush up how a mechanism of infertility occurs in endometriosis. So when it comes to minimal or mild disease, as you see in a video, there is a small implant on the ovary on the right side. So even this kind of implants, what they do is they changes in certain things in the peritoneal fluid, where there is an increase in the volume, increase in the prostaglandin levels, macrophages, with presence of interleukin and tumor necrosis factor, which is associated with a reduced sperm motility and binding. Also, it has associated with a myometrial peristalsis abnormality, so little abnormal myometrial contractions. Not only that, there is an increased progesterone and interleukin 6 and decreased VEGF, which leads to abnormal follicular growth as well as a bad quality oocyte, leading to affecting the embryo quality also. Then there are many other disorders like ovulation disorders or immunological abnormalities are known to cause infertility in endometriosis patients. Now, when it comes to a extent, I mean increased extent of involvement of the pelvic tissue, then it leads to a moderate to severe disease where we have reproductive organs which are attached to or adherent to each other. So these adhesions are actually distorting the pelvic architecture, where very important relation which we come across is a tubo-ovarian relation, where it is very, very important for the oocyte become after the ovulation inside the tube. So this tubo-ovarian relation alteration is very much common in case of tubo-ovarian adhesions or ovarian adhesions. Sometimes you have a lot of fibrosis at the end of the endometriosis, because of which you may get a distal end which is blocked and leads to hydrosulfings. Sometimes because of fibrosis, we come across tubal narrowing and constriction, and very rarely, not very common, but very rarely we come across in endometriotic patient proximal tubal occlusion. Now, if we look at the three types of endometriotic lesion, one is superficial endometrial lesions, as you see it in the first picture. Then we have an endometriotic cyst, which is completely located or secluded to the ovary. And third is a deeply infiltrating lesions, where it has penetrated into a deeper tissues. It has involved other pelvic organs or probably a deeper pelvic planes, and that is called deeply infiltrating lesions. Now we are going to discuss about infertility involvement as per these three categories. Now, what should be our goals of therapy when I'm handling a patient who is got infertility due to endometriosis? So one, we have to see to it that we want to preserve and improve fertility. So our intervention should not cause a damage. So we want to preserve her fertility undergoing any surgery for endometriosis. And at the same time, we have to keep it in mind, our surgical strategies has to improve fertility or reproductive outcomes after our ART involvement. At the same time, certain patients who are having severe dysmenorrhea, they should be able to have a relieved of pain. And third, the most important goal, to delay the recurrence for as long as possible for that particular patient. So either we have a fertility preserving surgery, or we have a second option is a fertility enhancing surgery. Now we will discuss about treatment of endometriosis to improve spontaneous conception. Means these are the scenarios where we do intervention and we leave the patient for a spontaneous conception. We don't advise her to undergo IU and IVF. So if we keep this goal in our mind, then the management guideline says that if you have a stage 1 or 2 endometriosis, which is minimal to mild disease, where you have peritoneal implants, you may have surface implants on ovary, uterine surface, or pelvic peritoneum. Here we want to do an operative laparoscopy where we do a excision of these implants as far as possible. If it is too many implants or it is little difficult at an odd location, you can at least fulgurate these endometriotic implants with the electrosurgery. And at the same time, if there are any adhesions, you must do adhesiolysis. So this is very, very important approach, because if you excise these implants, she is going to go back to her normal pelvic atmosphere, and that will help her to conceive spontaneously. Now, these are the minimal to mild endometriosis, and that is very important, that as you can see that, we have to pick up those implants, go below the plane, the deepest plane involved, and try to excise this implant completely. Now, if suppose there are 10 implants, try patiently and excise them as far as possible. But in case if they are very at a difficult location, probably, or they are very much adherent to the underlying surface, you can safely, where it is difficult to go and in the beneath planes, then it's better to do a fulguration of the these implants. So it is a very simple procedure, doesn't need a very large surgical skills or kind of skillful surgery. But when it comes to ovarian endometrioma that is undergoing surgery, remember, if we are looking at a spontaneous conception, then excision of endometrial capsule instead of drainage and electrocoagulation of the wall is definitely evidences that it increases the spontaneous pregnancy rate. Now, before we do this surgery, 2 points are very important. You have to counsel the patient that there is a risk of reduced ovarian function after the surgery, and there is a possible loss of the ovary in case of huge, large endometriotic cyst like more than 7 centimeter. And decision of repeat ovarian surgery should be considered carefully. If she has already undergone a surgery, we must carefully decide that if it is a recurrent endometrioma, don't take a decision of surgery, because it is going to further damage her ovary. So these 2 points, you must keep it in mind, and keep it in mind while doing like this kind of surgery. What you see that here it's a large endometrium on the left side, and here it is also adherent to the ovarian fossa. So first job is to release this ovary from that and then drain the cyst. Now, if you look at this principle here, see, it's like capsule is held by the one blunt grasper, and the normal ovarian tissue is gently pulled out of from that false capsule, because this is a very important surgical principle when you want to preserve a normal ovarian cortex from the that particular capsule. So we are going to lose some 10-20% of normal ovarian cortex or the stroma, but we will have conservation of, so kind of fertility preserving surgery we can do it. Now, third important picture what we see is the extra ovarian endometrium. Now here there is a false capsule, basically separating ovary from adherent surface, followed by drainage of collected blood, rather than trying to find a cyst wall is the most important step. See, the extravariant endometrioma is something, endometrial implants are either on the ovarian surface or the ovarian fossa, and they are also can be on the ovarian surface, and because of the repeated bleeding, there is a kind of encysted fluid, encysted area between these two structures, and all the blood collection or the collected blood is getting collected, and we see that as an endometriotic cyst. But complete exposure of deep infiltrating area of endometriotic lesion on the ovary is mandatory. You cauterize the exposed surface because you're not going to have a proper cyst wall in these areas. There is not much loss of ovarian tissue during this procedure, because understand this is extra ovarian. It is not completely intra-ovarian, where from all 360 degree the ovary is surrounded by a normal ovarian cortex. So here some part of the ovarian tissue is involved. So the moment you separate, you can just see a raw surface area and you can fulgurate. Sometimes you may get a thick capsule which you can excise. But to prevent the recurrence of adhesions, adequate cauterization with complete hemostasis is very, very mandatory, or you must use an interseed to cover the ovary. Now, the impact of endometriosis on the rate of pregnancy of patients submitted to IUI. Now, if you look at it, 129 patients, they were divided into three groups. One group was infertility patients without endometriosis. Second one was infertility with endometriosis stage 1 and 2, and then endometriosis 3 and 4. Now, if you look at pregnancy rate by the cycle in three groups, if you compare A and B group, then there is hardly any difference of pregnancy rate between these two groups. So this evidence in fact tells us that sometimes that minimal or mild endometriosis may not affect the IUI results. But when it comes to stage 3 and stage 4, there is a significant reduction in the pregnancy rate, as you've seen, only 5.6% in stage 3 and stage 4. So to simply speaking, even if you suspect endometriosis, but you don't see that ovaries are involved, you may suspect on transvaginal scan or per vaginal examination that it looks like a minimal endometriosis. There is no need to put a telescope immediately. You can subject this patient for 3 controlled ovarian hyperstimulation with IUI cycles, and if she doesn't conceive, then go for laparoscopy. So a very important point to understand. Now, it is always important that you have to combine IUI with controlled ovarian hyperstimulation in these kind of scenario, because it is going to optimize these pregnancy rates, especially in ovulation induction cycles. Now, at least minimum when it comes to controlled ovarian hyperstimulation, it's better to perform at least minimum 3 cycles. Now, if you look at the pregnancy rate, clinical pregnancy rate, which was significantly higher in stage 1 and 2 by this study in 2015, which was close to 64%, that is cumulative pregnancy rate. And if you compare this with stage 3 and 4, it was 45.6%. So it was significantly higher in stage 1 and 2. Now, even if you look at the live birth rate, stage 1 has got a significantly higher, that was 48% versus 34%. So COH-IUI intervention significantly increased the likelihood of pregnancy relative to that in the follow-up group during the 1-year study period. So they concluded that the IVF should be limited for especially stage 3 and 4 disease, and especially in a woman with more than 38 years of age in this group of patients. Now, considering the adverse effect of prolonged ovarian stimulation on endometriosis, IVF should be the first line approach in the management of infertility in this disease. So do not continuously do 6, 8, 9, 10 cycles of IUI in this group of patients, because ultimately we are creating a hyperestrogenic condition. So repeated stimulations can increase the disease. So quick shift from IUI to IVF is mandatory. So IUI should not be done more than 3 cycles. Now we come to the second presentation, which is endometriotic cyst management. Now, we have 4 questions when we are handling endometriotic cyst. Does endometriotic cyst affects fertility? Number 1. Does endometriotic cyst excision surgery is going to improve fertility? And third, what are the benefits of cyst excision? Does they outweigh risk associated with the surgery? And fourth is the complications of surgery. So let's understand about endometrioma, how it affects the fertility. So remember, friends, that it is mostly thought to occur through the invagination of endometriotic tissue or cells through the ovarian serosa. For example, during remodeling of the ovarian cortex after the ovulation. And it is usually presence of ovarian endometrioma. If you see unilateral or bilateral, always consider it as a moderate to severe disease rather than mild or minimal disease. So altered follicular environment, which is common, which is represented by elevated concentration of progesterone and interleukin 6, and that is my interleukin 6 and decreased concentration of vascular endothelium growth factor. They are responsible for alteration within the oocytes, leading to impaired fertilization capacity of the oocytes and reduced embryo quality with low implantation potential. As we discussed, that there are always abnormal endocrine, abnormal cytokine production around these lesions, and that actually is responsible for abnormal oocytes. So presence of ovarian endometriomas, especially if they are bilateral, they can affect ovarian reserve significantly because both ovaries are involved. So they impact the ovarian response to gonadotropins during our ART protocols. So histological study has already reported that there is a significant reduction in the primordial follicular cohort in affected ovaries because of the presence of endometrioma. And follicle depletion may be secondary to damage induced by endometriosis associated inflammatory reaction and by increased tissue oxidative stress leading to fibrosis that reduces the ovarian reserve. And it has been shown also that substances like free iron, they diffuse through the cyst wall of the endometrioma, as well as long lasting mechanical stretching on the effect on the ovarian cortex, all have a detrimental effect on the ovarian reserve. So in endometrioma, there are good chances of association of decreased fertility because of severe affection on the ovarian reserve, as well as compromising the oocyte quality. Both affects the fertility. Now, is there a critical endometrioma size associated with reduced ovarian responsiveness in an ART? So this was a prospective study in 2014, and here they suggested that there is a significantly lower number of follicles which are more than 16 millimeter and oocytes retrieved in the ovaries containing endometrioma. So there is a definitely involvement in terms of ovarian reserve, and they found that if the patient has an endometrioma more than 3 centimeter, the endometrioma size was the most influential contributor to the total number of follicles and oocyte retrieved. So the more higher size in terms of diameter of cyst, the lower chances that lower number of oocytes or follicles we are going to get. So ovarian endometrioma, they result in reduced response to ovarian stimulation compared with the response of the contralateral normal ovary in the same individual. So this we normally see it in unilateral endometrioma, that the other ovary is normal, we always get a more number of eggs, but we get a smaller number of eggs from the affected ovary. So 3 centimeter is one of the very important cutoff. Now endometrioma less than 3 centimeter in diameter per se does not affect ovarian reserve in ICSI cycles. So yes, this study says that if the endometrioma is less than 3 centimeter, the number of oocytes retrieved from these ovaries having this size endometriomas and contralateral normal ovaries, they were comparable. That was 5.9 versus 5.4. So generally, if the cyst less than 3 centimeter, I advise not to touch that ovary, and you go ahead either IUI, IVF, whichever is according to the other factors is convenient. But the meta-analysis clearly or systematic review says in 2012 that the more you operate, there is going to be a reduction in the serum AMH levels. So important decision about whether surgical excision is really mandatory or no, there are many factors needs to be considered. Now, when it comes to bilateral endometrioma, very important point, because both ovaries are affected, ovarian reserve is going to be significantly less. So what happens in this group 1 patients who has been undergone bilateral endometrioma cystectomy and the group 2 patient who did not undergo prior ovarian reserve? So women who is operated for bilateral cyst, they had a higher cancellation rate because of the poor response, because there is a significant reduction in the ovarian reserve. The number of follicles, oocytes retrieved and embryos obtained, they were significantly also lower in group 1 who had undergone a surgery. Now, if you compare clinical pregnancy rate or a delivery rate per started cycle, again in operated patient, it was significantly low than the patient who did not undergo surgery. So when it comes to bilateral endometriomas, be conservative for surgical decision and try and go ahead with the IVF directly instead of surgery. Now, are there any surgical therapies which are adjunct to treatment with ART? Now, for any other reason, if you are going to do ART, so are there any stage, like for example, during laparoscopy and your case is for ART, that is IVF, please go ahead and do a complete surgical removal of endometriosis because it improves live birth rate. These are the guidelines. If it is an ovarian endometrioma and if you are doing a surgical laparoscopy, then if it is endometrioma more than 3 centimeter, it is recommended to consider cystectomy prior to ART to improve endometriosis associated pain or the accessibility of follicles. So remember these 2 points. So if you see a bigger endometrioma, it's not that all patients needs to undergo surgery, but if it is your ovary is adherent and high up in the pelvic, which is very difficult to approach for oocyte retrieval also, I think it's worth putting a telescope and mobilize that ovary and get it in a normal position. Or if the patient has an associated gynecological complex like pain, then only you operate on endometrioma. Otherwise, you please go ahead with a IVF treatment. Now, severe endometriosis. As we discussed in the initial slides, these are deeply infiltrating endometriosis, which are associated with all sorts of lesions. Like you may have superficial lesions, you may have endometriomas, and you may have adhesions. and they are associated in a large percentage of patients. So DI lesions associated with endometrioma, there is a greater multifocality, and it is a severe disease, and it is associated with mostly intestinal and ureteral lesions. And so ovarian endometrioma is considered as a marker of severity of DI. So whenever you see a DI patient and there is association of ovarian endometrioma, you have to know that it is a stage 4 disease almost, and it's going to be our decision has to be very carefully to be done. So what are those indications when you are intervened surgically in severe endometriosis? When pain is so severe which is not controlled efficiently by medical treatment, though she is an infertility patient. Now, if the ovaries are not approachable, they are so high or they are so fixed that it is not possible transvaginally to do a oocyte retrieval, you mobilize the ovary by doing a surgical intervention. Or if there is associated hydrosalpinx, so before ART, you take care of hydrosalpinx by salpingectomy. If there is a recurrent IVF failure and there is no other cause, so it is unexplained, but you know that she is a case of severe endometriosis, go ahead and do the laparoscopic surgery for endometriosis. And patient who is just not ready to undergo ART, just doing the expectant management is not going to improve her chances of spontaneous conception, then you might go for a surgical intervention and leave her alone, because there are some percentage of cumulative pregnancy rate within 18 months after the surgery. Now, principles of surgical treatment: surgery only for symptomatic DI lesions. You have to take an informed consent. You have to have a multidisciplinary approach. So involve gastroenterologist or surgeon if it is bowel involved, involve urologist if it is a ureteric involved. But complete surgical exercise or exeresis in one sitting is very, very important. We don't want to put this patient for repeated attempts. Now, is there any role of preoperative hormone therapy? So like GnRH agonists. So giving preoperative hormone therapy reduced the size of endometrioma, but did not contribute to the reduction of the loss of ovarian follicles. So hardly there is any role for preoperative GnRH agonist supplementation, but post-operative GnRH agonist treatment has proven that they decrease significantly in patient. The recurrence rate is decreased significantly in patient who received 6 months of GnRH agonist treatment after the surgical intervention. So minimum 6 months ideally is indicated to give instead of only 3 months post-surgery. So we do have sometimes compromise. So friends, we want to be a good surgeon, but definitely we want to be a smart surgeon so that we do one surgery and we get away our endometriosis disease. Now, long-term pituitary downregulation protocol, I think that is one thing which I will, because right now I have discussed about some fertility improvement or fertility enhancing surgeries. But when it comes to IVF, especially patients with endometriomas, typically you see that they are the grade 3 and grade 4 endometrioma patients. So the live birth rate per woman was significantly higher when a woman received GnRH agonist compared to the control group where nothing has been given. And the administration of GnRH agonist for a period of 3 to 6 months prior to IVF in women with endometriosis increases her odds of clinical pregnancy by almost 4 times. So yes, down regulation is very, very important when it comes to endometriosis and IVF. If you look at this chart, the clinical pregnancy rate in a prolonged GnRH agonist suppression, especially in stage 3 and stage 4, has been documented by almost 82, where in only short agonist protocol, it was only 42, significantly higher in a prolonged GnRH agonist repair. Now, effect of surgery for endometriomas on fertility, yes, definitely surgical management has got some kind of benefits, but at the same time we have a significant risk of surgical risk of reduced ovarian reserve, post-operative adhesions and potential delay of ART. So be very, very careful in choosing your endometriosis. The time has gone now that where we used to see endometriosis and first decision used to be to operate, but now we know that our surgical intervention affects the ovarian reserve furthermore and also affects the ART outcomes. So be vigilant in taking. Now, this is an ideal ovarian stimulation protocol when you are putting stage 3, stage 4 endometriosis patient for IVF stimulation. So as soon as you arrive at diagnosis of endometriosis or endometriotic surgery has been done, you give a GnRH agonist depot 3.75 milligram, and then every 28 days you repeat these 3 drugs. Then after third GnRH agonist depot, 21 days later, you can start ovarian stimulation. 9 to 10 days, sometimes even 11 days stimulation is required because of prolonged GnRH agonist depot preparation, suppression. You do a ovarian stimulation, then give a SCG, because you can't use GnRH agonist. So be very, very careful in certain patient who's got a very high, they are higher hyper responder. You can have a hyper responder in endometriosis sometimes. So be very careful, because you don't have any option of using a GnRH agonist as a trigger. Here, its only option is using a SCG, and you do a oocyte retrieval, and depending on the ovarian response, you decide whether to do a fresh or frozen embryo transfer cycle. Now, which protocol is the best? It has been proven that GnRH agonist protocol was compared with GnRH antagonist, and in a long GnRH agonist protocol, all that number of follicles, duration of hyperstimulation, number of retrieved metaphase 2 sites, and total number of grade 1 embryos, they were all higher in GnRH long protocol, agonist long protocol, and I think that should be our answer. So to conclude my talk, ASHRAE guidelines group discussed the importance of women being appropriately counseled about the risk of reduced ovarian function following surgical intervention, and even the possible risk of oophorectomy. The decision to proceed with surgery for an endometrioma should be carefully considered. Not all patients should be operated, including the various prognostic factors that influence the success of ART, like age of the woman, look at the ovarian reserve status, look at the unilaterality or bilaterality of the disease, number and size of the cyst, very important, and symptoms also at the same time, presence or absence of suspicious radiological features which might suggest chances of malignancy. Now, asymptomatic women of advanced reproductive age, those with reduced ovarian reserve, bilateral endometriomas, or a history of prior ovarian surgery may benefit from proceeding directly with IVF rather than surgery, because surgery may further compromise her ovarian function and actually delay the start of the treatment. Last slide, surgery may be considered first line in a highly symptomatic patients, those with an intact ovarian reserve, unilateral and large cyst, and should be considered for cyst with a suspicious radiological and clinical features. Endometriomas may be associated with extravariant disease, including intestinal disease and deeply infiltrating endometriosis. Instead of chocolate cyst excision, IVF with embryo freezing followed by frozen embryo transfer in a downregulated cycle gives a similar pregnancy rate. So if you look at a bilateral chocolate cyst, or if you see a multiple chocolate cyst in both the ovaries, it's better that you downregulate that disease. In that downregulation, you start ovarian stimulation, get the oocytes, get the embryo, freeze that embryo. Then further, you decide whether you want to operate, and if there is, you feel that there is no, all those previous slide indication that there is no need of surgery, you can further downregulate her and prepare her for frozen embryo transfer in that downregulation. So never stop doing our best just because someone doesn't understand it. We need to do our best for our satisfaction and not for the others' application. So with this message, I thank you, KFOG, for inviting me to speak on such an important topic and close to my heart. Thank you all folks, and thank you ladies and gentlemen for the patient hearing.
Thank you so much, Kundan. Over to the chairpersons.
Thank you, sir. Thank you, Kundan, sir. That was a very excellent, sir, well updated talk. Actually, we had got an opportunity to learn lot in a short span of time. Sir, we can have questions, sir. If anything is from the audience, we can have the questions.
Sure.
Jyoti madam, any comments on the lecture?
Yeah, it was a complete overview with recent guidelines, and we could understand lots of controversies associated with endometriosis. So the first surgery should be the best surgery in the best hands. That's what we gather. And what about Dynogest prior to surgery and after surgery? Any evidence?
Yeah, actually, as I understand, it's a chronic inflammatory disease, and I think the way it takes more time to involve more tissue. At the same time, if you want to correct the disease before surgery with medicines like Dynogest, we need some more time. So sometimes if the patient is presented to you with some symptoms, but not eager to have a fertility right now, or not eager to have a child immediately, yes, it's a good drug to have a complete resolution of drug, because that is the only drug which has got a 30% chance of complete resolution of the disease. So, but when it comes to fertility, where patient has presented to you with the infertility, and then you have diagnosed them that to have a endometriosis, then sometimes in this group of patients, it's better to go ahead with the fertility treatments rather than putting them for a long time for diagnosis medicines. I think fertility is their prior symptom for which they are attending your OPD. So we have to respect our patients' symptoms for which they are attending our OPD, and then according to that, our advices do changes. So I will, when it comes to fertility, I'm concerned about giving medical therapy, especially like Dynogest. But yes, for short-term use, GnRH agonist depot are very surely they're pretty good, and they improve our ART success rate. It comes to IUR, IVF, they do increase our success rate when it comes to a short-term separation.
Thank you, Dr. Kundan. Any questions from the audience, Tejas?
Dr. Kundan, I would like to ask, because if the usually with endometriosis and infertility, if the age is more and the AMH is a little bit on the lower side, we may advise with endometrioma, we may advise ART. But in what all situation will you recommend surgery specifically, even if the ovarian reserve is less?
Yes, I think yes. I'm not against the surgery. That's point number one. But surgery is limited to when you have a unilateral endometrioma, kind of between say more than 3 centimeter, but less than 6 to 7 centimeter, and only typically intravarian endometrioma, not like extravarian, or there is a hardly any involvement of pelvic peritoneum. Yes, go ahead, because you have another contralateral ovary which is perfectly normal, but only unilateral endometrioma of this size. Yes, I think here even doing a surgery, a well-planned cystectomy is going to improve her chances of even spontaneous conception if there are no other factors in her case. So I think I'll recommend surgical intervention as I understood for ovarian endometrioma. That's what you asked me. So these are the few scenario where I will definitely do a surgery. Now, suppose if there are extra ovarian endometriosis, remember our surgical intervention is going to kind of improve her fertility, of course, but it's not going to improve her spontaneous conception rate. So typically only intraovarian endometrioma, especially unilateral, between 3 to 6 centimeter size will, and without any other factors, yes, her chances of spontaneous conception are high.
And in general, most of the ART people will tell that after surgery, IMH will come down. So ideally, till what time we should not do, we should not repeat IMH, or when should we repeat IMH after surgery?
I think I am, we routinely do AMH values before doing the intervention laparoscopically. So we assess, suppose we have a good AMH. Now, if you look at the AMH more than 2.6, it is the cutoff which is associated with a significantly higher live birth rate. I mean, there is a much assurity of the pregnancy. Now, if you have a patient whose AMH is at least above 1.6, which is a cutoff where you differentiate between the normal responders and the poor responders. So any AMH more than 1.6, I think safely go ahead. After your surgery, you can repeat AMH, but I think your antral follicular count is going to help you. Now, suppose if you are giving some GnRH agonist depot suppression for a longer time, possibly antral follicle count is not going to help you. So if you want to assess the ovarian reserve in this suppression, then only the AMH value is going to help you. So that's how you should do the investigations.
Nice talk, Kundan. It was well described.
Thank you very much.
Thank you, sir. Thank you.
Thank you. Thank you so much to both the chairpersons, Jyoti Madam and Sharad, for those lovely interactions. Thanks a lot, Kunjumuddin, Doctor, for chipping in with your questions. Thank you.